All right, should I go ahead and start it on up?
Yeah, go for it. Thank you.
All right, so probably most of these you individuals will be listening in on a recorded lecture, but for those of you who are here live, welcome. My name is David Walker. I'm an otologist at the University of Arkansas, and I will be talking about acute facial nerve paralysis. Some of this will cross over with some of the other excellent lectures you've already had. So for the sake of time and the sake of getting to Dr. Stack's lecture on time, we'll kind of cut through some of this and I'll direct you to the appropriate lectures that kind of have already been recorded and have already been done better than I could have even done. So no disclosures. If we go through an outline, we'll talk about anatomy, we'll talk about physiology and pathophysiology, the importance of history and physical, differential diagnosis, and then wrap it all up. So if we start off with anatomy, for most third-year medical students, this is probably where your understanding of facial nerve anatomy kind of stops after you take that anatomy test and most of the stuff goes outside the other ear. You're left with kind of the simple mnemonic and the simple understanding that the facial nerve controls muscles of facial mimetic motion. Once you're kind of doing your sub-eye, you start to graduate a little bit and you start to understand that otologists and otolaryngologists alike like you to know about the different segments of the facial nerve, and you start to gain a graduated appreciation for the complexity of its course. And eventually, hopefully, by the time you're a resident, you're gaining a graduated understanding of the complexity of both nervus intermedius and somatic fibers of the brachiomotor nucleus, which controls muscles of facial motion. Now, why in the world would I put on a lecture for hundreds of residents and show this terrible squiggly lined animation? And the truth is, I've done this lecture several times, and every time I will go through the image bank and try to find a better animation, illustration, cartoon, which demonstrates the course of the facial nerve, and I really can't find one. So there are prettier ones, don't get me wrong. There are beautiful ones out there, but this one's probably the most complete. So what this shows is that there are 4 brainstem nuclei. There's brachiomotor or somatic motor fibers. This is the facial nerve that we think of. There's the superior salivatory nucleus, trigeminal spinal nucleus, and tractus solitarius. Now, depending on whether or not these are efferent or afferent fibers, they may be leaving the brainstem or they may be arriving. But as we course these out, we'll kind of draw them out as, from cell body to their distal location. So let's go through the one that everyone already knows, which is the brachiomotor fibers of 7. So these are the muscle fibers. This is the cell body. It's located in the brainstem. It wraps around the 6th cranial nerve. It exits the pontomedullary junction, goes into the internal acoustic meatus. First genu goes to the geniculate ganglion. Cell bodies exist in the geniculate ganglion, but nothing actually synapses. Goes towards the 2nd genu, down into the vertical segment, gives off a branch to stapedius, exits the stylomastoid foramen, postauricular muscles, posterior belly of the digastric, and then muscles of facial expression, just like you guys all know. Probably the next easiest and most straightforward are those that are going to be arriving at this trigeminal spinal nucleus. So again, these will be flowing back towards the brainstem, but we'll trace them from proximal to distal. So again, exiting the brainstem, entering into the notoral auditory canal, cell bodies in the geniculate, but nothing synapses, down into the vertical segment, exits the stylomastoid foramen, and innervates a portion of the postauricular region as well as the contral bowl. So now we get into kind of the sticky ones, the ones that are difficult to give everyone a little bit of trouble. That leaves us with superior salivatory nucleus and tractus solitarius. So tractus solitarius, you'll see it actually has 2 fibers. There's a little pink one and there's a brown one here. The pink one is our general visceral afferents, and the brown one are special visceral afferents. So the brown one is taste, and the pink one is a little bit of just touch pain and temperature from the palate. So as we march these out, same course applies, goes into the internal auditory canal, goes towards the geniculate. You'll see that some of these fibers actually from both the pink and the brown go up and travel within GSPN, that's greater superficial petrosal nerve. We'll leave those until we come back to talk about the superior salivatory nucleus. But if we follow the fibers of that taste nerve, just the special visceral afferents from the brown fiber, on down, exiting the posterior tympanic canaliculus, entering into the middle ear, following down onto the infratemporal fossa and the lingual nerve, and getting taste to the anterior 2/3 of the tongue. Now, the interesting thing is that both within GSPN and within chorda tympani, there are multiple nerve fibers from multiple cell bodies within the brainstem. So you'll see there's a blue one here, and with the blue one of GSPN, there's a brown one and a purple one. So the one we haven't talked about is superior salivatory nucleus. That one goes into the internal auditory canal, into the geniculate, branches off at the geniculate, goes up towards the floor of the middle cranial fossa. This is carrying preganglionic parasympathetic fibers. And to give the full complement to the end organs of innervation, it needs to pick up sympathetic fibers as well. And it picks up sympathetic fibers from the carotid plexus within the foramen lacerum. It does that around here, and then drops down into the pterygoid canal or the Vidian canal, goes towards the sphenopalatine ganglion, descends within the greater palatine foramen and the greater palatine nerve to supply innervation to the soft and hard palate, and then rides up on the zygomatic nerve towards the lacrimal gland. Just as we talked about, there's also fibers that go and travel within the chorda tympani as well to innervate the submandibular and sublingual glands. So is it a lot of information? Yeah, it's a lot of information, but I think as we will see by the end of this lecture, you'll realize that there is importance towards understanding that there is a branchiomotor fibers of 7. Everything else is what we call nervus intermedius. And once you combine everything together, that's facial nerve proper. So you can use any illustration you want. I like this one. It's messy. It doesn't look particularly sophisticated, but it works for me. And I think it's a good representation of kind of what's going on a bird's eye view. So that's all well and good as long as we're dealing with a cartoon, but oftentimes we're asked to correlate these with radiographic images. So this is just a patient that I grabbed from, a scan that I was looking at last week. So we'll kind of run through this. Again, I know you guys have had several lectures on skull base anatomy, so we'll kind of zip through this a little bit. This is our internal auditory canal. We have our Bill's bar here. We'll call this the geniculate ganglion, and then probably a takeoff of GSPN here. You could make an argument whether or not this is actually geniculate versus the beginning of the tympanic segment of the facial nerve, but for sake of discussion, we'll just call that geniculate. Going back into the tympanic segment of the facial nerve in green, and then we enter into the vertical segment, which is right here. As we drop down, we start to see this takeoff here, and I would argue that this is most likely probably the chorda tympani. It's probably better seen if we move over here. This bony canal that it rides in is the posterior tympanic canaliculus, and it's easy to see on radiograph, but the anterior canaliculus, where it will exit and actually enter into the infratemporal fossa, is a little bit tougher to see. It's important to note that just from an anatomic perspective, that there is a variable break-off point for the chorda tympani. 70% of the time, it will break off right where you think it is, and it's going to break off within the middle segment of that vertical segment, but that's variable. 20% of the time will be more proximal, more towards that second genu. And 10% will actually be all the way down towards the stylomastoid foramen. Why is this important? Who cares? Well, cochlear implantation, as more and more individuals, even non-fellowship trained individuals, are engaging in opening up cochlear implant practices within their own practices, it's important to realize that there's a variable takeoff. This can save you a lot of time. And just from my own 2 cents and my own training, my general feeling is this is just one more reason to always find the nerve, because the variable takeoff of the chorda can lead to some angst if you actually don't know where you're going and you're just relying on matching up anatomic landmarks to find your recess. It's always going to be a little bit easier if you just find the chorda and find the nerve. Going back to our CT, if we zoom in a little bit, we see this kind of classic W pattern. I'll show you that again. So here's the facial. Here's the chorda, facial recess, pyramidal process, sinus tympani. So you can always find that W. If we zoom out again and we follow this down, we'll follow it down, and we start to see something a little bit peculiar that kind of pops out of nowhere. And you can find this actually on most scans. There's this little break point between the pars vascularis of the jugular vein and the chorda tympani. So what's happening is Arnold's nerve needs to make its way into the ear to supply the tympanic plexus. We know that Arnold's nerve comes from vagus, and around this area near the stylomastoid foramen, vagus will send off a branch of Arnold's nerve and it will track back into the facial nerve. It will not exist within the facial nerve proper arachnoid, but it will ride along it and it will branch off into the middle ear. You obviously have your inferior petrosal sinus as well, and this is always near that carotid-jugular spine. Why is it important to know where the Arnold's nerve breakpoint is? I think it's important from a resident perspective because I can recall several times where you're getting an evaluation for a facial or a temporal bone fracture, and by gosh, you can't even find this thing. You're looking all over for this, and you're trying to match it up. You're looking at other sides, especially when you're a second year or early on. You have no idea what's going on. The more natural sutures and breakpoints you can find within the temporal bone, the less likely you are going to be fooled in the long run, and the more natural these are going to appear. And obviously this will graduate to where it opens up into the stylomastoid foramen. So let's pop back up to the internal auditory canal. Remember I said the internal auditory canal was going to be red. We'll call it the green geniculate, and then GSPN breaking off, going towards the floor of the middle cranial fossa. You'll recall that I said that the GSPN is carrying from its brainstem parasympathetic fibers, and it needs to pick up sympathetic fibers to give the full complement to its end organs of innervation. It's going to travel within the floor of the middle cranial fossa, and then it's going to pick up sympathetic fibers from the carotid plexus within the foramen lacerum. From the foramen lacerum, it's going to enter into the Vidian canal. Just as a reference point, this is foramen ovale and foramen spinosum, travels, and it gets cut off here a little bit, but if we switch to more of a sagittal section, we see the Vidian canal, we see the pterygopalatine fossa, and we see the greater palatine foramen going down towards the palate. So hopefully by now, if you're a resident, you've graduated from the simple mnemonic and you're no longer thinking of facial nerve as just breaking it down within anatomic segments, but you're trying to think of it as a full complement, tracing all brainstem nuclei to the end organs of innervation. And hopefully by the time this talk's done, you'll realize the importance of that and why it's not just some type of trite anatomic exercise. From my own soapbox, one of the reasons it's important to kind of think about things this way, look at all the structures that we found just by looking at the facial nerve. These are non-intimate to the facial nerve, but with the exception of maybe the IAC, but we found a ton of different structures, and skull base anatomy is hard. If you can just know your course of the facial nerve, look at how many structures you can kind of tick off your box and say, okay, well, now I have a much better understanding of what the facial nerve is and where it's going and where it's traveling. Obviously, that's the macro, and here's the micro. You guys all know this probably. Axons are formed into bundles called fascicles. These are covered by perineurium. The fascicles themselves are bundled and covered by epineurium and form the nerve. So the physiology and pathophysiology, I changed this up a little bit in an effort to not put too many people to sleep. And by that, I mean showing you graphs of action potentials and electron micrographs of Wallerian degeneration. We'll kind of do something a little bit different. So this is probably the last thing you think of when you see a physiology and pathophysiology slide. Some of our predecessors. So this is Dr. Waller, Dr. Seddon, Dr. Sunderland, and Dr. Fish. And this might seem like a strange cadre of individuals because they seem to have all different interests with respects to the facial nerve, but I would argue that if you think of them in concert, it makes each one of their contributions make a little bit more sense. So we'll start with Dr. Waller. In 1850, he published his Sentinel paper, and most of you already know. He was transecting hypoglossal nerves and glossopharyngeal nerves on frogs, and then watching over the course of 3 days, upwards of a week, of the anterior aspect of the stump slowly starting to degenerate. Called this Wallerian degeneration, and it's critical in terms of understanding its impact in terms of neural recovery for peripheral nerve injuries. Dr. Seddon took Dr. Waller's work and asked himself what aspect of the nerve actually needs to be damaged in order to get to Wallerian degeneration. So he published his efforts and came up with a classification system to basically look at three different groupings of damage. He called these neuropraxia, axontomesis, and neurotomesis, and we'll get into them in just a second. Dr. Seddon's predecessor was an orthopedic surgeon named Dr. Sunderland. He extrapolated on Dr. Seddon's by basically making neurotomesis into three subsections. Now, when you're learning about this and you're studying for in-service and you're studying for boards, this is kind of where we stop. And you just have to know these sections and you have to match up what neuropraxia is with what actual neural structure is damaged, and that will get you the point. But if you think about it from afar, you can fairly easily ask your question, well, what's the point? You know, if somebody comes in with Bell's palsy or idiopathic facial paralysis, I'm certainly not going to take a biopsy of their nerve. I'm not going to try to see exactly what section of the nerve is damaged. What's the point of all this? And the point is that we can start to kind of predict the degree of degeneration and regeneration. Now, the same question comes back, which is, well, how do I do that? I'm not taking a biopsy. I'm not really going to know whether or not the epineurium or the endoneurium is damaged. And that comes into where Dr. Fish played. So Dr. Fish, obviously most of you know, and this is where we'll kind of truncate a little bit of the talk because I know you've had a couple lectures on electrodiagnostic testing for the facial nerve, but he was very interested in the prognostic value of electrical testing. So he was able to tell that by using ENOG within an appropriate time frame, we could identify patients who had neuropraxia. The important thing to realize is that electroneuronography can't really differentiate between whether or not you have 3rd degree versus 5th degree neurotomesis. But the fact that it can pick out neuropraxia, both within the Seddon and Sunderland classification, either neuropraxia or 1st degree block, is critical. So I would argue that if you think about it less from a standpoint of studying for in-service and just thinking about, well, Waller's over here, Seddon and Sunderland are in the middle, and then there's this Fish guy doing whatever he was doing. If you think about them in concert, it starts to make things a little bit more significant and make things make a little bit more sense. So we'll talk about history and physical. So this comes from, I believe, Bailey's, and it goes through basically any number of different diagnoses that could be applied to somebody presenting with acute facial paralysis. Now, what's the point of putting this up? Well, the point of putting this up is not to go to your next otology clinic and present to your attending that perhaps the patient has leprosy or perhaps the patient has mucor. That's ridiculous, right? So the importance of this is to understand that there's a broad differential diagnosis. That being said, you know, between 60 to 70% of the time, if you're going to Vegas and you're placing your bets and you're placing your wagers, the majority of the time you're going to be right. If you just go to your attending and say, hey, I think this guy has Bell's palsy, you're probably going to be right about 60 to 70% of the time. But that means 30 to 40% of the time you're going to miss something. And if you miss something big, you're going to be in trouble and the patient's going to have a bad outcome. So the importance of, you know, this particular talk and the importance of this understanding this particular disease process is to broaden your gaze. Think about this from a standpoint of when you walk in the room, okay, this is probably, you know, odds are I'm going to be idiopathic facial paralysis, but it could not be. And the job is of your interview and your exam and your role as a physician is to prove to yourself that this is indeed Bell's palsy and idiopathic facial paralysis. That starts with the history and physical. So, you know, one of the more important things is figuring out whether this is sudden or gradual. The literature varies on the time frame of this, but by and large, most people would agree that within 72 hours, if you've had a progression to a complete facial paralysis, that could very reasonably be described as sudden or acute. Anything after that would be more gradual. You know, the classic gray area is what about 4 days? What about 5 days? Usually you can tease it out with the rest of the history, whether or not something is going on, but usually within 3 days, if they're progressing to a complete facial paralysis, I'll still include that as a sudden or acute loss. Audiologic symptoms obviously are not common with Bell's palsy and should kind of stoke the fire as to the fact that we're missing something else, probably more likely within the CPA or the IC. A history of infection preceding this, whether that be a GI infection or upper respiratory infection. maybe adds credence to the idea that this is primed from an immunologic perspective and gives credence to the idea that this may be Bell's palsy, is important to ask. A history of trauma. Oftentimes, people can present with acute trauma and acute facial paralysis, but very rarely people will end up with delayed facial paralysis. And you'd be surprised if you don't ask about this, they will not tell you. So if they get in a car accident and they walk away from it and their face is working perfectly, and 3 days later they experience a facial paralysis, some people won't put it together and they won't offer it to you unless you ask. History of recent travel. This is a map of Lyme's disease. We think about it from a stance of the Northeast, but oftentimes within the Midwest as well, and within different pockets, it's endemic. So I think asking about these individuals, asking about recent travel history is important. Other neuropathies, whether or not it's recurrent and if it's bilateral. This scale off to the side, the way I think about this and the way I think about facial nerve paralysis and acute facial nerve paralysis is I'm constantly kind of stacking blocks on a scale. And I'm trying to figure out where the scale balances. Is this story matching up with Bell's palsy? And if it's not, how much is it missing the mark? The more it misses the mark, the more my suspicion is raised, and the less likely I am going to be to follow the consensus practice guidelines published by our governing body, and maybe more likely to enter into other diagnostics. From a standpoint of the physical exam, otoscopy, tuning forks, neurologic exam, a comprehensive head and neck exam, you want to examine the oral cavity, you want to examine both the superficial and deep lobe of the parotid. Getting an assessment and a baseline assessment of their ocular exam, especially in the acute setting when this is several days going by, is extremely important. I can't tell you the number of times somebody comes in and they're 1 or 2 days out and their eye looks reasonable, and they come back and they are a week out and their eye looks terrible. And it's very clear they've not kind of gone through and ascribed to the recommended ocular precautions. It's important to have that documented, and it's important to be able to counsel the patient so that they don't risk anything as severe as a corneal transplant, which sure has been reported. And then obviously a competent facial nerve exam. Over here off to the right, you can see, if you just stick a handheld otoscope and you just look at the eardrum, you may see just, a normal ear, maybe a little bit of erythema along the lateral aspect of the malleus. But if you miss this cholesteatoma up here, because you're just doing a perfunctory exam, you just look in, that completely changes things. So this was a patient who in fellowship actually did have a partial facial paralysis from an epitympanic cholesteatoma. And if you just stick your otoscope in there and you take a quick peek and you pop it out and you're getting ready to you just want to get that House-Brackman documented, you're going to miss something like this and you're going to do the patient a disservice. We obviously know about the House-Brackman scale. The classic thing, I think, testing question is the delineation between 3 and 4. 4 not being able to close their eye completely and 3 being able to close their eye completely. I will go ahead and tell you and admit some stupidity on my part. When I was a resident, I can't remember, probably too old to make the mistake, but there had been a skull-based case, and they had, from what I had heard, at least from the senior involved in the case, was they had sacrificed the facial nerve. So they wanted me to check on him for evening rounds. I checked on him. I did my facial evaluation. And lo and behold, when I ask him to close his eye, he closes his eye. He doesn't close it completely, but by gosh, that lid closes. So I send a text message and I tell him, good news, the patient is closing their eye. The attending calls me. He says, are you quite sure of that? And I said, yeah, I'm positive. And he said, well, what grade would you give him? I said, well, I don't know, somewhere between a 4 and a 5, but he's definitely closing his eye. He comes up, he explains to me the obvious, which is that's not so much a closure of the eye, that's just a release of the levator. So he's releasing the levator, he's getting a Bell's phenomena of the globe, and the lid is closing ever so slightly. So when you're early on and you're a 2 and a 3, don't make my mistake. Realize that you're allowed some lid closure just from the release of the third nerve and the levator, and that doesn't necessarily constitute full facial motion. These are some historical tests that I think, unfortunately, our in-service still likes to talk about. These are the idea of topodiagnostic testing. The idea is that if you go back to that squiggly line drawing that I talked about in the very beginning, you can try to identify the site of lesion using electrogastrometry, using the Schirmer's test, or using the spit test, where you have somebody lean over a vial and collect their spit and measure it to normal variance. Obviously, none of these are practical, and none of these really change management all that much. So I certainly don't use them in my practice. I don't know anyone who uses them in their practice other than probably for research purposes. But unfortunately, with the way that our exams go, it's helpful to at least know about them. And again, this is that idea of electrodiagnostic and topographic testing. So the idea is that you can start to match these up and say, okay, well, he has a normal tearing test, but he has an absence to pedal reflex, and the electrogastrometry is all off. So that means the lesion must be somewhere around this area. In actuality, does that help you any? Probably not. So let's move on to kind of the crux of this talk, which is the differential diagnosis. So we go back to this pie chart. And again, hopefully the next time you go into a facial paralysis patient, you immediately pick up the chart and you think of this pie chart. If you're going to Vegas and you're pushing all in, chances are you're right. It's going to be Bell's palsy, but your job and your goal is to ask enough questions and not ask enough different exam questions and do a proper exam to convince yourself that you're not within this other area of the pie chart. So it's all about building that scale. Bell's palsy, we already kind of know the epidemiology of this. Fortunately, we have consensus practice guidelines, which help govern our practices. If you haven't gone through these, I suggest you do. And if you haven't gone through these, we'll do it right now. So we already kind of went through the importance of the history and physical. The importance of the history and physical is that it makes sure that we're on the right track. If things aren't matching up and the person tells you, well, over the past, 3 weeks, I've had this gradual progressive facial paralysis. It's really similar to the one I had 2 years ago. That's less likely to be Bell's palsy and certainly more likely to raise some red flags. So history and physical is paramount. Laboratory testing, recommended against. They kind of give themselves an out here by saying routine laboratory testing. It doesn't mean that you can never do laboratory testing, but it certainly means that it's routine. So if somebody went camping in the Northeast and they come back and they have a facial paralysis and you're 90% certain that it's Bell's palsy, but you're just not ever so certain that it couldn't be something like a Lyme's disease, this gives you a little bit of an out. The same for diagnostic imaging, routinely performing it, recommended against, but again, it's just about the routine. Oral steroids, antivirals in combination. This was looked at many years ago with Cochrane reviews, both within acyclovir as well as within corticosteroids. And what they found at that time was that there was insufficient evidence for the practice. Many people knew that this was providing benefit, but there had not been a well-done study to actually examine this. So that laid the groundwork for individuals to run an excellent study and publish their results within the New England Journal of Medicine. They took about 750 patients. They stratified them into individuals either getting acyclovir or placebo, and from those arms, either getting prednisolone or placebo. So there was going to be somebody who was matched up with it as acyclovir and prednisone, somebody just acyclovir, somebody just prednisolone, and somebody just placebo. So here's what they found. The top is, the red is prednisolone, the blue acyclovir plus prednisolone, placebo plus placebo, and acyclovir. So there's two things to realize. One is that patients who were receiving steroids did better. The other is that a dramatic percentage of patients will improve by 3 months. And then there will be a second kind of slow wave of individuals who get full facial function back by 9 months. So, within this group who was 85% fully recovered of the prednisolone, over the next 6 months, you'll still get another 10%, which is important when you talk about counseling patients. This ultimately is the fuel that helps us kind of make the recommendation for the guideline action statements to suggest oral steroids as being a strong recommendation, antiviral monotherapy being a strong recommendation against, and combination therapy being an option. I personally don't do combination therapy for straightforward bells. Eye care really can't be emphasized enough. It's one of those things that you hear all the time, but until you actually see it go awry, it doesn't drive home the point. And so I've seen patients who have been sent home with, poor ocular instructions and come back. And we did have a patient in, I can't remember if it was in residency or fellowship, but they were on the verge of needing a corneal transplant because their abrasion had got to such a severe level. The ophthalmologist eventually got them back on the straight and narrow, but this is big time. This is severe. As I tell patients, we have one problem, let's keep it to one problem. We don't want to start, adding things up and playing domino rally. With electrodiagnostic testing and its role within determining candidacy for surgical decompression, I know you guys have already gotten at least one, maybe not even 2 lectures on that. So I will defer much of the discussion regarding kind of the nitty gritty of most of that to those lectures, which I'm sure are excellent. Just briefly know that there are different types of electrodiagnostic testing. The goal of electrodiagnostic testing is to determine what patients are experiencing Wallerian degeneration, what patients could be reasonably expected to have good outcome without intervention, and what patients might need to be candidates for a surgical decompression. This is Dr. Gantz's kind of seminal paper within our field, which stratified patients into 2 different kind of protocols. If you were in acute paralysis, an acute paresis, basically you just got prednisone. If you progress to a paralysis and within the time period of being able to have an ENOG, you would go over into this particular kind of flow chart. And basically the flow chart ends in whether or not you have less or greater than 90% degeneration compared to the fully functioning normal side. And if you were greater than 90% degeneration, a potential option for a decompression was offered. He found that basically there was a break point around 14 days where patients no longer had as good of an outcome as those who came after. And again, this is the day of surgery after the onset of acute paralysis. So after 14 days, things start to drop off. And as we always say, we got to draw the line somewhere. And so that's where we draw the line, is essentially within 14 days. This is kind of a different display of the data, but again, patients who got midcranial fossa decompression within 14 days had a better outcome than those who got steroids alone. When you look at this study within the concept and within the scheme of other studies, the Cochrane review even says that it's limited by the kind of strength and the overall robustness of the data. So was not able to provide a firm recommendation for or against. Probably more interesting is the attitude towards facial paralysis, meaning how do neurotologists such as myself feel about their comfort with midcranial fossa decompression? So this was done before my time, several years ago. And basically they asked patients, asked practitioners, would you recommend surgical decompression? 21% said they would offer it and that they believed it offered a better recovery. About 25% said they would offer it but let the patient decide. And close to 50% said they would either offer it selectively or it was not indicated, which is interesting. In a different study, they asked patients if they met criteria, would they decompress? More said yes, less said no. And perhaps most interesting, I think this is probably the most interesting of all the slides, which is how many surgical decompression cases have you done in the last 10 years? So the last 10 years, there have been, the majority of practicing otologists and neurotologists have done less than 5. So that's 1 every 2 years. That's not a lot. So take it with a grain of salt. I think that's probably why they list it as no recommendation. Acupuncture and physical therapy. Why can't we just gloss over this? This seems so boring. Why are we talking about acupuncture and physical therapy? Well, the reason we're talking about acupuncture and physical therapy is in the setting of COVID and COVID-19, we know that, when in doubt, just go to Amazon and type it in and see what we get. And look at all this stuff. We get facial stimulator, facial treatment, facial massager, Bell's palsy oil, who knows what that is, Bell's palsy facial electrical stimulator, facial stimulator unit, facial massage. So I can't tell you, I think I probably had 3 patients within my fellowship who would come in with these little boxes that looked like, torture devices. And they said, well, we got this off Amazon. Is this okay to use? What do you tell that patient? Well, you can tell them that there's actually been a Cochrane review of this. And when they've looked at the overall number of studies, there's only about 12 studies that actually meet any type of rigor that would be subject for inclusion in any type of meta-analysis. And when you look at the biases for all these, again, green means no biases, yellow means questionable biases, and then red, obviously, no good. All of them are wrought with complications, and all of them are wrought with bias, which culminates to basically say that there's no recommendation. So you will see these patients. These patients will come in with electrical facial stimulators, and their question will be anything from, does this work? Can you help me turn this on? Can you tell me how often I should use this? And I just always go back to the data and say, listen, our consensus practice guidelines offer no recommendation. I'm in no position to provide you with a treatment regimen of this type. And if you'd like to do it, you are kind of on your own, but I can't in good conscience recommend something that may not help, but may also potentially hurt you. And obviously, want these patients coming back. So what about things that are non-facial nerve paralysis? What about trauma, or non-Bell's palsy? What about trauma? This is kind of a rudimentary flow chart that I think you would be okay following. Again, I don't think anything is fairly groundbreaking within this. Again, basically the idea is if you have an immediate facial paralysis, there is an argument that you could go for surgical exploration. Although, as you'll see from the data, that's not always as cut and dry. So much of the data behind nerve transection and nerve repair comes from World War II data, and you'll see a lot of stuff coming out from Walter Reed. There is this idea and this notion that's somewhat antiquated that the maximal amount of axoplasmic flow and anterior grade reconstruction and cell body metabolism is at this 21-day mark. And this will get spouted off over and over when you look at regenerative papers regarding facial nerve paralysis. The important thing to realize is that this is kind of born out of antiquated data, and the idea behind it was that people would time their reconstructions for facial nerve transections and peripheral nerve transections to meet with that 21-day mark. In actuality, I think if you had a family member and they had a facial nerve transection and you had the opportunity to repair it, you would most likely be upset if the physician said, we're just going to wait 3 weeks. I think these patients are probably better served by a little bit quicker action. If we talk about the treatment of temporal bone fractures, this is from Dr. Rodney Diaz out in California. So here are patients who had complete facial nerve paralysis after trauma. These are individuals who had non-operative, and here are individuals who had operative. And you can see from patients who had non-operative to patients who had operative, there's not that much of a drop-off. We'll exclude the transected because those individuals, obviously, not only do they have poor outcomes, but are in a completely different subset. So this would offer the idea that, with a lot of these patients who are presenting with non-transection injuries in the setting of trauma, that you can wait on them and you can see if they come back. And after talking to my partner, Dr. Dornhofer, that's kind of more and more what we do. We don't particularly push surgical decompression, and oftentimes we'll see these patients will have a pretty good outcome. Here's a separate study from Dr. Cole, formerly of WashU. He looked at individuals who either had transection injury or not, and their ultimate house grade after the injury. And you can see that basically, if you're having a transection injury, no matter when you're repairing it or what you're doing, you're not having a great outcome. And I think that people think about doing a cable or a jump graft and getting somebody back up to an operational level of a 3. I think that's the goal, but in practice, oftentimes that's not what we're able to achieve. Perhaps a different way of looking at things, but it's kind of driving home the same point. So this kind of grayer box are individuals who are managed by just conservative management, black boxes managed by operative management. And as you can see, as the operative management becomes more paramount, the outcome becomes worse. Kind of speaking to the credence that maybe that initial flow chart that we mentioned that kind of shows up in a lot of books, maybe should give you a little bit of pause. I think the bottom line is this is practice dependent, but within my practice, I'm fairly conservative with these individuals and I'm not running off to do surgical decompressions on non-transecting injuries. The big question, I think, is when you do have a transecting injury, what do you actually tell the patient and when do you time the actual reconstruction? That's the big question. Acute otitis media, there was one paper that actually looked at patients who had acute otitis media in the setting of facial paralysis. And the long and short of it is, I'll leave this up so that you guys can peer at it, but these patients do remarkably well as long as you treat the acute otitis media. There was a story from fellowship of an individual who was young enough to tolerate an in-person or an in-office procedure, presenting with an acute facial paralysis. They did a full history and physical. They looked in the ear. He had a bulging eardrum. They were able to put a tube in clinic. And by the time the tube was in, the facial nerve paralysis had completely resolved. So these patients do remarkably well. Not everyone, but more often than not, if you treat them appropriately, the facial nerve will respond. There's a number of different hypothetical kind of pathogenic mechanisms, but the take home is that these patients do well. Chronic suppurative otitis media, completely different disease entity, completely different ball game, and maybe somewhat surprisingly, not a lot of data on it. A lot of the data comes from third world countries and is kind of lacking in terms of its power, but there are a couple. Basically, as it's a different disease entity and a different disease process, it makes sense that there's a different pathogenic mechanism. And I think that by and large, with the absence of data that's available, my own practice and that of Dr. Dornhofer's is that urgent surgical intervention is required. The debate becomes how kind of aggressive do you become with these? Do you do a decompression? Do you do a canal wall up? Do you do a canal wall down? I think it's, unfortunately, this is probably one of the least helpful slides within the talk because it is a nebulous disease entity and it's a case-by-case basis. But I think these are certainly ones where phoning a friend and asking somebody their opinion is helpful. If this is an individual where you don't have fellowship and you don't have fellowship training, I think this is certainly one that would be more than reasonable about phoning your fellowship and or phoning your place of training and saying, hey, do you mind taking this patient off my hands? Just as an aside, this is somebody who had a canal wall down, and this was in fellowship. They were coming in from an outside individual who had cleared them to have ear molds. So they put ear molds in, and obviously there's this dangling facial nerve in the breeze. They put the ear molds in, and the patient developed acute facial paralysis. So I can tell you that this is not the way that you want to have your Friday night go, by taking this patient back to the operating room to peel out ear mold from around a dehiscent facial nerve. The patient ultimately was fine, but obviously some anxiety for the practitioner who was not within our own practice. Herpes zoster, this one comes up not as infrequently as you might imagine. Kind of has the classic medley of ear pain, hearing loss, plus or minus, dizziness, changes in taste, and dry eye. So here's the classic manifestation of disease. And I've always wondered, at least when I was a younger resident, what's the deal? Why are they having vesicle eruption within the conchal bowl? It's this virus that's kind of traveling under the skin and then invading into the nerve. And maybe the conchal bowl is just so close to the stylomastoid foramen. Kind of what's the pathogenesis of this? Well, the pathogenesis we already talked about in the very beginning of this whole talk, and I told you it would be important to understand the full complement of the anatomy. And that is that the conchal bowl is innervated and has afferent fibers which go back to the trigeminal spinal nucleus. And this is invading and reactivating within branches of nervus intermedius and impacting the facial nerve proper to give a facial nerve paralysis. What about this patient? They might have like a little hemotympanum. Do they have a little bit of irritation to the Q-tip injury? Well, no, they actually have herpes zoster as well. So this person has a facial nerve innervation, which is supplying the canal. So without a careful physical exam, you could reasonably think this is just some mild irritation, but this is actually vesicular eruption on the tympanic membrane, consistent with herpes zoster. What about this individual? So this individual, you got it, has afferent fibers coming from the chorda tympani, jumping onto the lingual, into the infratemporal fossa, through the anterior tympanic canaliculus, into the middle ear, posterior tympanic canaliculus, facial nerve proper, all the way back to tractus solitarius. Does this patient have herpes zoster? Yeah, they have herpes zoster. What about this guy? Well, remember we have the greater palatine nerve coming up to the pterygopalatine ganglion, going back into the Vidian canal, going back and picking up fibers from the foramen lacerum, hopping up into the floor of the middle cranial fossa, going to the geniculate ganglion, hopping onto facial nerve proper, and then going back into the superior salivatory nucleus. Does this patient have herpes zoster? Yeah, they do. So broadening your gaze from just looking for conchal bowl vesicula to looking for vesicular in any aspect of innervation of the facial nerve is important. Probably the most important thing for these patients and why it's important to spot the vesicles is that these patients have a poor outcome. They do need antivirals, but they need to be counseled appropriately, that they have a worse prognosis. These are emotionally charged visits. And when patients come and they tell me, well, I was diagnosed with Bell's palsy, and it's very clear that they have Ramsay Hunt. And not only does the counseling change, but the treatment changes. There is a lot of resentment. It's emotionally charged. They're extremely upset. And there's always the what if. What if I had just gotten the antivirals earlier? Truth be known, we'll never know, but the importance of nailing the diagnosis early and accurately, it can't be understated. Lastly, if you're practicing in a long career, you may spot one of these, with the exception of acoustic neuroma, which you may spot a couple, but the important thing is to not miss it. In terms of kind of what you're clinically looking for and what kind of shows up on boards and in services, are these expansile lesions of the geniculate area. Here's one that's kind of traveling within the course of the GSPN. And again, you'll probably see maybe one of those within your career, but keeping in mind, particularly as it relates to metastasis from the skin, as well as the parotid and the deep lobe parotid component, you want to be mindful of that. So in wrapping this up, I would just underscore, the next time that you're in an otology clinic or the next time you're in a general clinic and you're picking up a chart or you're clicking on Epic and you see facial paralysis, immediately the thing that should pop in your head is this pie chart. Okay, odds are this is Bell's palsy, but I got to prove it to myself that I'm not missing something. So I'm going to ask all these questions and I'm going to build my little, balance to where I can positively say with good confidence that I'm on the right track or I'm not on the right track. And I think if you just walk in and you say, oh, you have facial paralysis, well, it's got to be Bell's palsy. Or, oh, I went to the emergency room and they diagnosed me with Bell's palsy. Well, the emergency room, they're infallible. They must be right. I guess you have Bell's palsy. You're doing the patient a grave disservice. Chances are you're probably right. It probably is Bell's palsy, but you got to be sure. So asking the questions, doing an appropriate physical exam, and identifying those patients who are out there who need further workup. That's the take home point of this whole talk. And again, just keeping in mind that does everyone who presents with facial paralysis have cat scratch disease? Lord, no, but they're certainly out there. The strange ones are out there, and they're going to present differently than the acute facial paralyses. Hopefully this was helpful. If anyone has any questions, I'm sure my email is easily accessible. Hopefully everyone's staying safe, staying sane, and as we kind of get back up ramping on and kind of moving towards more normalcy, hopefully we'll see each other and bump into each other at the next conference. So I think Dr. Stack is up next, and I'll leave you in his capable hands here.